So thank you for the opportunity to share some of my work today. I have a lot of interest in developing better tools for spine surgery and brain surgery. To give you some background, I'm originally from here, born and raised, and I basically did my training in Detroit, went to Boston, came back, and I thought I'd be sort of in private practice. And so they told me, get really good at spinal fusions because you're going to come back and do all of our lumbar decompressions. And so I was like, oh, okay, great. And I have a little bit of an interest in video games. I was played professionally for a little bit, and then I actually had a big spinal deformity correction when I was younger. So you can't tell now. So naturally, my lab works sort of in this space. And I feel very fortunate to be working in this age of a lot of rapid innovation. And so we've been doing some work, and I think it behooves a lot of us, I think, to push technology and push ourselves kind of to the edge, particularly since we're the surgeons and sort of responsible for pushing the technology forward, at least in our fields. I have no disclosures yet. So can't start a talk about augmented reality without first paying homage to image-guided surgery. This doesn't include the robotics literature, which obviously is still being sorted out, but the tenets basically of what image-guided surgery offers us surgeons is for accuracy, placing our thoracolumbar screws with high accuracy, helping to understand the complex anatomy of deformity and tumor cases, and for example, seeing your case in 3D intraoperatively is very important. Allows us to do cool things like cervical pedicle screws, which I'll be honest, I'm not comfortable doing freehand. Radiation obviously is a big advantage to doing image-guided surgery using preoperative CTs and lessening the amount of fluoro that you use. And then obviously outcomes as well too. I'm not going to go over all the little details of all the different studies, but just as we mentioned earlier, even decreasing the number of returns to the OR and sort of the overall case savings of some papers quoting upwards of even $10,000 per case. So some of the drawbacks, obviously, most of us are sort of familiar with this. Just by a raise of hands, how many people use image guidance in the OR for placing screws? Just curious. Okay, yeah. So I think it's been increasing over time. I think one of the papers, I think from 2015, was showing something like 10 to 20%, but I think it's probably a little bit more now. And so I think most of us will kind of understand that there is still somewhat of a human factor to this. Most of us are familiar with, sort of relying on the fact that you have a reference array that hasn't moved or that your resident hasn't bumped, or even the patient after, for example, hammering on their spine. And there's also the time factor because there's increased time in obtaining the registration. And then, of course, the ergonomics of turning your head, looking at the patient, going back and forth, and losing accuracy. And then also just the fact that the machine itself is so bulky and takes up a lot of space in the operating room. So to introduce, basically, this talk really should be called mixed reality because in spine surgery, AR is meant to be kind of a display-only technology where MR displays more of the virtual images that we can actually interact with. And so the videos to the left are from my lab. One of them is done in Sketchfab and the others with HoloLens. Let me see if I can, there we go, yeah. So the one up on the top left, that's an example of VR, obviously virtual reality. And then the one on the bottom left that's an example of a heart. I couldn't bring up the spine one, but we have no Wi-Fi here, so. But the bottom left example is basically using the first generation HoloLens. There's actually a HoloLens 2 now that we use, but you can display obviously malleable objects utilizing the room and sort of the surrounding objects as references. And so you can obviously imagine in the operating room that this would allow you to intraoperatively access anatomical data, maybe a pre-planned overlay of what you suspect or what you wanted to do, or your plan B or plan C, as some people have mentioned before. Or if you just had questions about anatomy in real time, for example, where is the aorta or the vena cava or whatnot. And so people have been using AR and MR for almost a decade now to do a wide variety of procedures. So there's everything from obviously just the traditional heads up, the idea of just having all of the imaging available to you, all the way down to facet injections. And so the list kind of keeps growing every year. And we won't have time, obviously, to go into all of them, but this doesn't even include the other applications for things like neurosurgery, gen surg, orthos, a lot of literature in ortho as well. And for anybody who's tried a heads-up display, you'll immediately recognize the value. You can get pretty clear visualization of what's underneath. You can maintain your eyes on the patient, obviously, as you're doing your operation. Most studies parallel the accuracy for image-guided techniques. The ergonomics, there's basically less shifting of your attention. You get less line of sight issues as well, too, with the reference array because you're sort of just standing there. And then, there is an argument in some ways for training because, some people think, well, this is going to take away the ability for, residents to learn freehand techniques and things like that. But I actually think that it's a valuable tool for training because you can, with some of these tools, you can actually show the anatomy intraoperatively, and you can show the entire room. And so it actually, in some ways, almost reduces the learning curve of these challenging procedures. And we're actually, hopefully, going to be investigating some of those things in medical students because I don't have any neurosurgery residents here. So Sella, this is actually one of the first prototypes done in a mannequin in 2011 in Germany. And so their model, they used basically a PC tablet screen and a reference marker that was attached to a rectangular board that was scanned with the patient. So they had to individually segment the structures, and then they superimposed it onto the mannequin. And using a video stream, basically, they displayed it on the tablet. And so you can see the user interface in the upper left-hand corner is obviously very rudimentary, but it's still an impressive setup, given that they were just basically using a depth camera, which is like a small Intel $200 camera, and a single marker basically for the registration. But that's how easy the navigation actually is. It's basically made from technology that was made in some kid's garage basically back in the 1970s. And we're still using that same technology today. And so that's obviously evolved. There have been a number of different advances using a number of different displays. This is the most common, I think, currently, at least in the field of AR and MR. The Microsoft HoloLens. There actually is a HoloLens 2 out, and that's what most everyone is using. It's unique because it actually tracks your eye movements and your gaze deviations and your head movements, and so it's probably the most popular for that reason. The main advantage actually is that you can sort of take AR into the realm of MR, where you can bring up additional information, you can overlay it, it's in your field of view, you can use gestures to control and bring different types of information into your field. And so this is actually, in a lot of ways, more of like the updated Apple sort of thing where every year there's like a different version. I think they're already working on their next HoloLens along with their updates. But it's given me enough faith, I think, to believe that one day we might all be wearing a HoloLens to pull up records, images, consult somebody from halfway across the world, or even answer your calls intraoperatively. And there's still a lot of work that needs to be done. For example, the current models, they have a lot of problems with image quality, visual fatigue, for example, because it's displaying the image essentially directly onto your retina. And so one of the things that a lot of people complain about, for example, is sort of like this feeling like you're being overwhelmed with digital information. The quality, I talked about that already. And then one of the other disadvantages is that well, at least currently for some of the models that are out there, there's a focal length that's fixed, and so you have to work at a particular focal length in order to have the images come up. And then the actual weight of the headset itself. There is a learning curve to this as well, too. And I don't know if this video is gonna, I guess the video is not gonna play. Could you try to click on that video? It might not come up. Oh, you don't have Wi-Fi, that's right. So anyway, there is a little bit of a steep learning curve. This is a video out of Seattle, but it's using some technology I think it's called AR, surgical AR, I think is what it's called. But nevertheless, despite some of these drawbacks, I still think that there's going to be sort of like, again, like the iPhone, there's going to be new updates and newer versions that are hopefully going to overcome some of these challenges. Currently, right now, there exists just one commercially available platform called Xvision. It's in the upper left-hand corner there. I'm sure some of you have probably seen videos and stuff of it. The published accuracy of this model in particular matches that basically of just traditional image guidance. The outcomes, I think, are still being collected. But I expect that we'll probably start to see an increase in clinical studies and that type of thing over the next few years. There are other companies on the right-hand side which are sort of working in this realm and with very promising and very interesting things. Mediviz in the upper right-hand corner, I think, was started by a neurosurgeon based out in New York, and he's primarily in the brain realm right now with really neat things, and the user interface is actually quite amazing. But they're looking for spine applications. OnPoint is right around the corner, I think, with coming out with something as well too. And even in the general just academic world in the bottom right-hand corner, I don't know if this will play, probably won't. Yeah, but they have this sort of own version using a QR code based type of navigation. So that's kind of AR just as a quick sort of overview. But anybody have any questions? Now we'll get to lunch.